Marvin Goldfried is a distinguished professor of psychology at Stony Brook University, where he helped to develop the graduate program in clinical psychology. He's the co-founder of the Society for the Exploration of Psychotherapy Integration. Alan Francis is a professor of psychiatry and chair emeritus at Duke, and was chair of the DSM-IV task force. Marvin describes the evolution of his psychotherapy orientation as psychodynamic, behavioral, CBT, and eventually integrative. He practices, teaches, and supervises what works clinically using direct and indirect evidence base. Alan describes his approach to psychotherapy as whatever works, or no one size fits all. He was trained and taught at the Columbia University Psychoanalytic Center, but remains equally interested in brief, supportive, cognitive, behavioral, interpersonal, and family therapies. Please enjoy this week's episode.
Good morning and Happy New Year, and welcome to Talking Therapy with my good friend and colleague, Alan Francis. Good morning, Alan. Happy New Year.
Hey, Marvin, you too.
And I'm Marvin Goldfried. And so today we're going to continue our dialogue on when therapy makes the patient worse. And Alan, you said you have an awful lot to say about that, so let me bounce off you.
Okay. I like to divide it into four different categories. Situations in which it's likely that instead of being helpful, therapy will actually create more problems than it's worth. The first category would be poor therapist-patient match. The second category would be the poor technique patient match. The third category would be bad therapist. And the fourth category would be patients who are particularly at risk for getting worse in psychotherapy. The first thing, therapist match, we did a study, an informal study a long time ago when I was at Payne Whitney. It was really interesting. We had the notion that we should never blame a patient for a therapy not working. And if a patient wanted to switch therapists, we had a no-fault easy divorce policy, where if a patient felt the therapy wasn't working and there wasn't a compelling reason for the patient to continue in the therapy, we would just allow a very quick transfer to someone else. And we followed 75 switches. The results were remarkable. In all but a few cases, the patient did much better with the second therapist. And even more interesting, and surprisingly, it wasn't as if there were a few really bad apple therapists and everyone who was getting out of therapy was getting out of therapy with a few people and they were bad for everyone. It turned out that the person who was a terrible therapist for one patient was a wonderful therapist for another. That the people receiving the referrals were the same people who were losing patients, but they did better with the new patients. And just the change of scenery was very helpful. Change of match was very helpful.
Did you have in mind the kind of new therapist that would be required for the patient?
There was a little bit, it wasn't controlled, it wasn't a very careful experiment, but there was some thought of, this didn't work so well. What kind of therapist do you think it could work better with? And we would take into account a little bit, like a lot of therapists, a lot of patients said, well, I think I would prefer to have a woman or a male therapist, as the case may be. Okay. Some said, I want someone who'll talk more. And we would, to some degree, try to find a therapist that would meet the desires. So it was also a confound. It wasn't just the person we were sending the unsatisfied patient to, it was that they were getting more control over who the therapist would be.
So you asked the patient what they were looking for.
Yeah.
And there has been subsequent research on this. I don't know it, but I know people have done research on that, of giving the patient a say.
Also, with some people who had gone through lots of therapists and were unhappy with all of them, I would say something like this, that, you've been through 5 therapists and you haven't liked a single one of them. That could be you just had terrible luck and all 5 of them were just terrible therapists, or it could be it's something you're bringing to the situation. I'm willing to try you with a couple more to see how much it's you and how much it's them. But if it keeps on happening, then we'll have to assume that maybe you're going to have to change your behavior some. And the remarkable thing again was that very rarely did we have to make second switches. That the first switch was often very positive. How much that was just a better match, how much of it was the person feeling they had more control over it, not clear.
That is so anti-psychoanalytic in a good way.
Yeah, the idea that it's always the idea that if there's a problem in the treatment, we should always jump to the default conclusion that it's transference and the patient is reliving some aspect of their past behavior. That's absolutely true with many patients and many therapies, but it's absolutely wrong in many other situations. And I think that the less the treatment is avowedly psychoanalytic, the less time that's been spent together between the two people, the more likely it is it's just a bad match.
Now,
And the therapist has done something that pissed the patient off. And very often, if the therapist will admit, yeah, I know I did this, it pissed you off, and I've learned from that, that will lead to a better relationship. But when therapists always assume that, if you're angry at me, it must be because I represent someone in your past, that pisses the patient off even more, because as likely as not, it's something the therapist has done, not a transference reaction.
Yeah, it's like the patient is always wrong because what you see is not what's there.
Yeah, and
really, it's a derivative.
Transference is an enormously valuable tool when used well, but it can also be a defense for the therapist to never investigate what in their behavior might have created the feeling, to always assume it's a recrudescence of a past relationship rather than something that's happening in the room at that moment, is to miss the immediacy of the interpersonal relationship and to, in effect, blame the patient for any trouble that happens in therapy.
When you were looking around to pick another therapist for some of these patients, did you also recommend other therapeutic orientations that might fit?
That's the second category. That it's not just the relationship; it's also the technique.
The technique, okay.
Yeah, and the kinds of problems that we saw that, and I've seen in many other contexts over the years. I think that the most frequent is therapists going for change in situations where the patient really can't change. So most therapists are not trained in supportive therapy. It's a tremendous deficit in training programs. The supportive therapy is probably the most common kind of therapy given in the real world. People should be great at supportive therapy. It's much harder in some ways than cookbook psychodynamic or cognitive or behavioral therapy. And the mistake that we saw most often was therapists being way too ambitious beyond the patient's desires or capacities and forcing on them an effort towards change that was too stressful for them to handle.
You know, this is not the first time you recommended supportive therapy in our dialogues. And I've been thinking about that and wondering, because at least within CBT and maybe some of the other orientations, they don't talk about supportive therapy, but they talk about other things that may be the same as supportive therapy. So what do you mean by supportive therapy? You know, when is it indicated and
unfortunately, supportive therapy is usually the control group in the research study where there's a favored therapy that's hope to be demonstrated as effective, and you need a control group, and supportive therapy is thrown in as the control group. And the interesting thing is that very often supportive therapy does as well as the designated therapy. That's why there's so many tie-scores in the literature. Supportive therapy, to me, is a treatment that's aimed not at changing the patient's behaviors and defenses and emotions, but rather at supporting their strengths. That rather than trying to uncover problems or to develop new coping skills that may be difficult for the patient to acquire, it seeks to find the strengths in the patient's current behavior and helps them to cope with enormous problems that they have in their external life or enormous problems they have as a result of their psychiatric issues. So supportive therapy doesn't aim to change the patient. It aims to enhance what's strongest and most resilient in the patient's behavior. And it's a relationship-based effort that you're not offering so much a technique of treatment as a supportive relationship. usually over
That-
a considerable period of time.
What you've described sounds an awful lot like CBT and helping the patient learn coping skills.
No, this is the difference, not learn new coping skills.
Yeah, no, this is building on the existing coping skills.
Supporting the ones that have been there and maybe temporarily lost. It's not meant to change the patient into a higher level of functioning. It's meant to help them support whatever functioning they have at that moment and to recover things that may have been temporarily compromised due to external stress, physical illness, or a psychiatric disorder.
Mm-hmm.
There's a very good book on supportive therapy recently published by John Markowitz, and actually came out of a research study where he was comparing it. He wanted to get proof that IPT worked, and they developed a supportive therapy arm. And that supportive therapy arm was well done, and the book well describes it.
Interesting.
But it's not described enough. Now, getting beyond supportive therapy, I think that the other.
Let me just finish up a little bit more on supportive therapy, because this is correcting or clarifying what I have had as a misconception. I've thought when you talk about supportive therapy that the person is not able to change because of constitutional factors, severity of the problem, duration of the problem, whatever factors.
External stressors
that in their environment.
Ability resources, and they don't want to change.
Yeah. So you get them to accept what's there. And I view that as supportive therapy, but maybe that's not it.
Accept what's there and also optimize what's there. And to restore hope, to reverse demoralization, to find silver linings in dark clouds. To be there when there's a shoulder that needs to be cried on, offer a supportive relationship, to be helpful, give advice when advice is needed. That all the things you're told not to do in straight psychodynamic therapy or in manualized CBT, all of those things that are part of the human relationship are perfect for supportive therapy.
Okay, but
the reason why people are bad at supportive therapy sometimes is because they've been overtrained and taught not to give advice, not to give comfort, not to be available in a real relationship sort of way, so that you almost have to untrain people of their technical, surface behaviors that they've been taught in psychoanalytic school or in CBT school or reading a manual, and let them go back to the more basic humanitarian, caring skills that most people have even before they begin training in therapy.
So I'm understanding this as there's partial overlap between supportive therapy and certain aspects of CBT. Coping.
Oh, I'll put it another way. Supportive therapy is part of every therapy.
Right.
It's usually not recognized as such.
Yeah.
And for some people, it's the only thing that will be useful in therapy, and trying to do anything more may actually be harmful.
So I guess the question is, when people get harmed because they need supportive therapy and other interventions are being pushed, but don't seem to either be working or maybe are not really appropriate, what keeps the therapist from switching?
Well, I think most therapists don't value supportive therapy and don't realize how important it is for a pretty large segment of patients. And also, most therapists have been taught to do the opposite. So if you read Twitter, you'll see therapists recommending never give advice to patients.
Yeah.
Never give comfort to patients. Don't joke with patients. Don't have a real relationship with patients. Almost the ground rules that they're taught as part of their CBT training or psychodynamic training, those ground rules are the exact opposite of what many patients need.
Yeah.
And we value supportive therapy and not see it as a second-hand therapy, but rather in itself enormously useful. The training programs would extend to try to do what's right for each patient rather than teach a model in an isolated, flexible form.
So you use the term ground rules. And, I'm a big fanatic when it comes to words and what they mean. By ground rules, are these theory or school-driven assumptions? Who sets the ground rules that you don't give advice?
Well, I think it's interesting that Freud, by the way, was constantly giving his patients advice.
Mm-hmm.
People couldn't shut him up. Patients who described it couldn't shut him up. He was talking all the time. He was very real. He was a supportive therapist.
Also asking for financial contributions.
Yeah. He took patients on vacation with him. His patients saved him from the Nazis. It wasn't as if he was this austere blank screen. Yeah. But when psychoanalysis got filtered through the Berlin School of Psychoanalysis with Karl Abraham, it became purified in a form that made it suitable for many fewer patients. And the ground rules of psychoanalysis that influenced American psychoanalysis inordinately, because the Berlin School is much more influential than Hungarian school in American psychoanalysis. Those ground rules created this artificial idea that a therapist is a blank screen, that he mustn't relate to the patient in a realistic way. And what they did at the same time was make it almost impossible to be a suitable patient for analysis. Yeah. But one of the problems the analytic schools have always had is finding patients. And the reason is they've established a kind of therapy that only works for a very narrow slice of the patient population.
So you know what you're saying, Alan? You're saying that a bunch of guys, and it was predominantly men, in a certain European country at a certain point in time decided that this is the best way to do therapy. And
there was opposition.
Many people continue to follow.
There was blowback, and there were attempts very early on, Ferenczi and Rank in the 1920s, and Alexander and French in the 1940s, and Malin and Sifnios and Davinloo in the 1960s and 1970s. There was blowback to try to create a more practical form of psychoanalysis or psychodynamically oriented therapy that would apply to a greater number of patients, would be useful for a greater number of patients. But the analytic schools tended to coalesce around the most inflexible ideas, the most demanding inclusion criteria for patients. And as a result, they became so rarefied, the techniques are often not helpful for most patients who need help.
So if I could try for a psychodynamic interpretation of this phenomenon, that there are therapists who are practicing, and unconsciously they are following certain guidelines that have been set in the past under different circumstances, and they may not even be aware of the origin of it, but it keeps them from sometimes giving the patient what they need.
Exactly. And a similar thing with cognitive behavior therapy. There's no more flexible group than Tim Beck, now deceased, Judy Beck, his wonderful daughter, and the group in Philadelphia that have done the most training in CBT. But despite their flexibility, despite their saying often and early and often that the manuals were only developed for research purposes, they weren't developed to guide clinical practice. Despite their saying that you mustn't rigidly adhere to manuals, that because the manuals are the easiest part for therapists to incorporate, way too many cognitive behavior therapists work by the book. And instead of following the patient, follow the technique. So that's a case, if we're going to balance the harms that can be done by excessive rigidity in following psychodynamic principles, we'd also have to recognize that some therapists are excessively rigid in following behavioral principles. Some therapists are excessively rigid in following cognitive principles, and that these can be equally harmful when they don't apply to what that particular patient needs.
So the guideline is nothing as helpful as a good theory.
In other words,
necessarily the case.
We have to be sure that people don't become worse therapists because they're overtrained and inflexibly trained to follow whatever therapeutic theory or guideline they assume will produce best results. Because those guidelines usually, and any rigid adherence to one type of technique usually means that you may be not just neutral, but may be harmful to certain patients for whom that technique may not be well suited.
And the harm, since we're talking about harmfulness, may simply be that they're not getting the best treatment and they are being harmed financially. And there's years of their life where they're not functioning as well as they might. had they been involved in a more appropriate therapy.
Yeah, it's just like many patients on medication they don't need, but they don't know they don't need it and stay on it for very long periods of time, suffering side effects with no beneficial effect. Similarly, many patients will stay in a psychotherapy that may either be neutral or actually harmful. And you're right that any therapy that's not helping in some way is hurting, in, at least financially, at least in the time that's being invested.
I recall I told you an example of when I was on a panel, and this analyst described several years of traditional analysis with a phobic patient, and finally cured the phobic patient after many years. There was harm there, and they had to suffer from the phobia for many years, where they could have had that alleviated much sooner had therapy been different.
And that brings us to the third and fourth categories. The third category would be bad therapists. And I think in my experience, there have been a few people I've known who I really felt should have gone into another field. And they were hopeless from the beginning and got no better with training. And it really was, I think, a failing on the profession to let them become licensed and let them treat people, because they really just were either they were bad people or they were just bad at doing therapy. They were just bad interpersonally. But that's the minority. I think the majority of the bad therapists I've known were good people, potentially excellent therapists who had been trapped by excessive adherence to a model.
Yeah.
So I've met any number of therapists who I really thought were wonderful. And when I referred patients to them after they graduated the program, the patients would complain that they wouldn't talk. And why wouldn't they talk? They'd gone into psychoanalytic training. They misunderstood what psychoanalysis should be like, and they became just blank screens, and the patients found them useless. So I think that it's not just, I think the very minority of bad therapists are bad therapists because they're bad people. The majority of bad therapists are bad therapists because they excessively and simple-mindedly follow a particular technique, whether that technique is psychodynamic or behavioral or cognitive, that they go by the book rather than going by
this is a tricky kind of thing. When I first started doing bad therapy, I was a bad therapist. I didn't really know what the hell I was doing.
Yeah, but you were a good person, Marvin,
Yeah.
and you were a flexible person, and you were a person who was willing to admit, I don't know what I'm doing.
No, I was in my 20s.
Yeah, but those
I
are
don't know how I was in my 20s. I'm not the same person I was when I was in my 20s.
Yeah, I think that's both ways. I think you could say, well, people get to be better therapists with age and with experience. Yeah. The trouble with that is that some of the best results I've ever seen have been with first-time patients, first-time therapists. That there's an enthusiasm and a willingness to participate in a wholehearted way that many therapists lose as they get more jaded and tired and sort of more routinized in their work. So I'm not sure that it's just a question of experience, that you can say that there's a simple correlation that you get better with experience.
All right, let me repeat myself. It depends, it depends, it depends. Because we are talking about therapy as if it's one thing that we all recognize, but it's a multitude of things. Some people would say giving advice is not therapy. From their point of view, it's not therapy. But from somebody else's point of view, it is therapy. And if it helps people, I come out of the session and say that was a real good session, then it was therapeutic. So maybe people need to change their definition of therapy and realize that there are other therapies. Also, there are different patients who need different things. I mean, you and I have had disagreements because you would say, well, the kind of patients that I've seen are much more severe and, real pathological than the kind of people that I see in my practice or I see in a clinic situation. And so it depends on the patient as well. So there are therapies and there are patients, and we're trying to come to some conclusion overall. And depending on what part of the elephant we're discussing, we'll come up with different conclusions.
Well, I love what you said, Marvin. I love when you said it depends. And the therapists that worry me are the ones who don't realize it depends and say, well, therapy by definition doesn't include advice, or therapy by definition doesn't include giving comfort, or therapy by definition doesn't mean providing hope. Therapy means whatever that person thinks it means. I think anyone who has this narrow definition of therapy is entitled to have their opinion, but they're likely not to be effective with many of the patients where it depends, where for them they need something, a much broader, much more flexible intervention than that particular therapist provides. And I think when you get bad results in therapy, it's partly because a therapist is following these rules rather than following your, I think, perfect advice. It depends.
Yeah. I'm thinking of cartoons, contemporary cartoons of therapy. And what do you see? You see somebody lying on a couch and the therapist behind that person taking notes. We don't see cartoons about CPT because they'd be very boring. But we have a stereotype as to what therapy is for the lay public. And I think, that's also perpetuated depending on the therapist.
And that stereotype also doesn't do justice to psychodynamic therapy, so that much of what I did in my career was psychodynamic therapy, but it was psychodynamic therapy that was sitting up usually once a week, sometimes for as little as one session, sometimes for 12, sometimes for 12 years, but it was sitting up and it was interactive and it was using basic psychodynamic concepts of the past influencing the present, people not being aware of a lot of the reasons for their actions, but using them in a real life kind of situation, not blaming everything on transference, and not expecting that every patient's going to need years and years of treatment. So psychodynamic therapy is not that dissimilar from cognitive therapy. The cognitive therapy has gotten closer and closer to psychodynamic therapy, and flexible psychodynamic therapists have gotten closer and closer to cognitive therapists over time. There's one last thing I think we should discuss before we end, and that is that certain patients are at particular risk for being harmed by treatment. I think one type of patient is the one you mentioned earlier, the person who becomes unnecessarily addicted to treatment. So just as people can become unnecessarily addicted to medications that aren't helpful, treatment itself can become very seductive and a way of hiding from making changes, a way of hiding from real life, a way from avoiding doing the things that need to be done. And I think a major enemy of an effective, helpful treatment is the therapist and the patient becoming too comfortable with the status quo. I'm very eager to encourage status quos in supportive therapy, but if the therapy is meant to encourage change, it shouldn't go on without any beneficial results for months and years on the assumption, well, it will all work out later. That very often the therapist and the patient should entertain the assumption that they become so comfortable in therapy that it's almost an excuse not to change.
Right. And you can get indications of this when they describe a problem that they've had during the course of the week, and they wanted to wait until they saw their therapist in order to figure out what happened or what to do in the situation. So I think that's a flag.
Especially if that happens after a long period of therapy. So
yes.
If that happens in the first week or two, well, that can be very useful. I'm trying to use the therapy to understand myself better. But if that happens in the second or third or fourth year, it's suggesting that the person is using the therapist as a support, even in a treatment that theoretically is aiming at change.
And the therapist is not recognizing the supportive nature of it.
Yeah. Partly because therapists become dependent on the situation too.
Yeah.
That if you like a patient, it's not easy to picture giving them up. It's fun seeing them every week. They're paying you. It's easy to get into a relationship with a patient where they don't really need the support, but you do.
Yeah. To say nothing of the payment. given inflation, given the cost of college education for one's children or grandchildren, that can sometimes serve as an implicit motivation to keep up your caseload.
The other type of patient, very different situation, who's harmed by therapy, is the person who's been in many therapies and not gotten better.
Yeah.
I think when you see someone who's been in many therapies and not gotten better, it may have been that they had poor matches along the way. It may have been with the therapist. It may have been the techniques were wrong along the way, but it also could be that therapy for that particular person can be toxic.
Yeah.
And particularly, it's been my experience that this is the case with those people who develop excessively intense relationships with the therapist.
Yeah.
Usually are very intensely hopeful at the beginning and then very intensely disappointing somewhere down the road later on.
Well, let me close on that note by just telling you what I tell supervisees. And if they pick up a case where the patient has more experience in therapy than they do, then the probability is that they, the therapist, will change more than the patient. They don't like to hear that, but that's the way it is.
And I told you, I think in an earlier session, I wrote a paper 40 years ago called "No Treatment is the Treatment of Choice." And for some people who've proven through many treatments that they've gotten worse in treatment, what I said to them is we have a pretty good track record that treatments don't help, that they may make you worse, that maybe you're better off taking a break from treatment and see what happens. I think it's important not for it not to be experienced as a rejection. So I would say, why don't we follow up, come in a month or two without treatment, and let's see how you've done.
Mm-hmm.
It'd be very interesting for you to have a period of time when you get a rest. And also for people who've been in long treatments, if something happens, the therapist dies, the therapist retires, it doesn't usually make sense, unless it's a supportive therapy, to jump into another treatment.
Right.
It's good to have a period of time to let things settle and to try to see how well the person can function in life without having the crutch of being in a long-term treatment relationship.
Good common sense.
Yeah, that's all therapy is.
Yes, band and follow the patient. Boy, we're going to put supervisors out of business and teachers out of business. But
well, you have to unteach people having all sorts of strange ideas about what they think therapy is in order to let themselves be themselves and to be helpful in a way and flexible in a way that patients really need.
again, good advice. See you next week. Stay
You
safe.
too, Mark. Take care.
And Happy New Year again.
Yeah, you too. And to all the people who are watching or listening.
Absolutely.